Ciao mondo, hello world, hola mundo, hello mon, konnichiwa, ni hao, namaste. Again, we're here in Asiago with the special group of ADQI Conference 36 on the link between extracorporeal lung support and AKI, fluid management, and possibly CRRT. And this conference just occurred after the International Vicenza course. I'm lucky enough to be here with Professor Emily C. from the University of Melbourne, and she is co-chair of Group 3, which is dealing what?
It's dealing with the application of renal replacement therapy during ECMO.
Okay, and what are the challenges that you have encountered in this issue?
So our group is looking specifically at the timing of initiation of RRT during ECMO, also how we should prescribe it, and finally how and when it should be discontinued or transitioned to an alternative modality. The challenges are that a lot of the studies that we have available have been performed in mixed critical care populations, so having to extrapolate and apply the data from the general population in the ECMO population and make specific recommendations to guide clinical practice has certainly been challenging. We've been able to identify similarities between ECMO patients and also general critical care populations, but we've also been able to identify important differences that clinicians should consider. When we look at the initiation of renal replacement therapy, the thresholds at which therapy may be indicated are different in some unique ECMO populations, and so we've been able to identify some of these nuances from clinicians. Importantly, we've also been able to work out where the field needs to go in terms of future research directions, and we're hoping that our colleagues around the world will be able to take on some of these recommendations and perform subsequent work to answer some of the questions that we haven't been able to.
What is the main take-home message from your group?
The main take-home message is that the ECMO population is unique, and applying all of the general principles to that population is inappropriate. So ensuring that the prescription and delivery of renal replacement therapy is individualized to the patient in front of us is critically important.
And you're not talking just about renal replacement therapy, but also other techniques such as hemoadsorption and plasmapheresis, etc., right?
Correct. We will be expanding to look at other extracorporeal blood purification, which again has important nuances, especially between adult populations and pediatric populations. So having such a diverse range of experience amongst the faculty has been really important for ensuring that our recommendations apply across all cohorts.
Do you expect there is a potential for application, for example, of hemoadsorption to remove specific cytokines or any other molecule that is induced by ECMO?
I think that's a really important point, especially after the cardiac surgery data that's come out recently about hemoadsorption. What we need to understand though is, in patients receiving ECMO, when should hemoadsorption techniques be applied? What biomarkers can we use to guide their initiation and also duration of applicability? But certainly there's active work going on in this space, and we're looking forward to seeing the outcome.
Thank you, Emily, and thank you for following today's Cappuccino from Asiago, Italy, 36 ADQI Conference. And have a wonderful, wonderful day. Excellent.
Excellent.